Hello everyone, good evening. This is Dr. Khan from Novi, Michigan. I want to go ahead and welcome each and every one of you to another Facebook Live. Welcome to the new members, the audience members who have just recently joined my private Facebook support group, and to the many others who are listening, who are curious to learn about breast implant illness. And so what I want to do, basically introduce myself very briefly. I'm a board-certified plastic surgeon by the American Society of Plastic Surgery. I'm also a board-certified general surgeon. I'm also certified in burns. So I've done 10 years of training, and basically as a board-certified plastic surgeon, I started off my practice doing everything but augmentation, which is what is the most common procedure that plastic surgeons do. I chose deliberately, purposefully not to do that procedure, which is breast augmentation using implants, for I did not believe in it. And I saw the many patients in my training over the years that the detrimental effects of the implants. And so as a result, I basically now explant exclusively, and I've been doing that for a long time. And now 90-95% of my practice is basically dedicated to what is explant, and in the en bloc fashion, a total capsulectomy, such that the patient gets the best experience possible. I basically, from my training around the chest and also hand surgery, lower extremity reconstruction, and also skin cancer, I have basically had the experience and the expertise from the many professors who have taught me over the years in the world of general surgery, trauma, from the gunshot wounds to the chest to the trauma reconstruction after breast cancer reconstruction with microsurgery, along with hand, which is an integral part of plastic surgery. Basically, all plastic surgeons are hand surgeons who are ASPS board certified, and that almost a fourth of the exam, if you will, is hand surgery. And that we choose to do the many different operations that our careers take us to, such that we offer that to our many patients, be it craniofacial, be it burns, be it oncologic reconstruction, breast reconstruction, skin cancer, amongst the many others. Now, having said this, plastic surgery has 3,000 operations, to quote my chair, my mentor, who trained us, and to basically focus in on what is explant surgery. Just a brief introduction about myself. Now, having said this, what I want to do is I want to go ahead and answer some of the questions that the patients have. I want to go ahead and talk about how I do it and why I do it differently, what the many patients are talking about, what is explant surgery. And then basically, briefly, I want to go ahead and go over what are the 5 different ways that I've said many times, and I'll go ahead and repeat these, that kind of ensure or confirm or authenticate that the explant surgery is done right in the en bloc fashion. And the way I, as a board-certified plastic surgeon who does these repeatedly, foresee that this is the ultimate and the best way. And this is what I say to my patients, and I've said before, 20 years from now, I cannot imagine how the surgery would be done any differently. So essentially, the gist of the whole explant surgery, the en bloc, is the fact that the entire capsule, along with any inflamed tissue, be it fatty tissue or whatever it may be in the periphery where the silica may have, quote, migrated to or leached out, that needs to be removed along with the implant as one system, preferably in the en bloc method, such that there's no breaks in the capsules. That is the en bloc method, or a total 100% or a total capsulectomy, where the entirety of the capsule is removed. If there's any break in the capsule, that automatically is not an en bloc, and that becomes a total capsulectomy when the entire capsule is removed along with the implant as one system. A partial capsulectomy is not optimal and is incomplete resection of the capsule, such that that residual capsule will continue to hurt and haunt the patient, and the patient will continue to have the many signs and symptoms of breast implant illness. So again, the integral part, and why do we know this? For 2 reasons. Number one, we know from the many pathology reports that the capsules then have in it the silica, the foreign body reaction, the giant cell reaction, the inflammation, the leaching out of the silica, the refractile foreign bodies that basically that I have shown in the last few pathology reports and the many others over the last several months. And you don't want to leave this burden behind. This is hard evidence, physical proof that the capsule has in it the toxicities and the impurities, and that's why it's integral for the capsule to go. Also, we know anecdotally from the many patients who have had an explantation done by an inexperienced plastic surgeon, you see the patient does not bounce back from their breast implant illness symptoms. They are less severe, but they are still present. And only when the patient goes back to another reputable plastic surgeon who does en bloc surgery and the residual capsule is removed, only then do we find those patients where they have relief of their symptoms of BII and the many symptoms of what were partial relief now become complete relief, and hence reaffirming the fact that the entirety of the capsule must be removed such that the patient gets a fair and a very definitive bounce back. So I have a patient that I saw last week. She has full-blown rheumatoid arthritis. She was under the assumption that if she were to remove her implants, her symptoms would improve. Now, she came to me on the first post-op visit and the second post-op visit, and she said, well, my joint pain is still there. I still have difficulty getting out of bed in the morning, and I'm essentially the same like it was. And I said, well, this is your breast implant illness, essentially looking at, or what was supposedly masking what was your rheumatoid. This is your underlying rheumatoid. Now, time will tell how she recovers. Maybe her rheumatoid may be less severe. But in her case, I told her with reassurance, one thing I can assure you with confidence and a guarantee, and this is the 5 things that I will talk about. Well, there is no capsule remaining behind. There is no inflamed tissue remaining behind in this equation of what is your health. The implants have been removed along with the capsules plus inflamed tissue. So this is not part of your problem. And I can say that with certainty. And she accepted and she believed the fact that this is her rheumatoid. And I said maybe after some time, a few months, hopefully she goes into equilibrium with her body and she does not have the severity of the rheumatoid that she had. 2 things for a fact. Number 1, implants are not meant to be in the body forever. 100% proven. The FDA even acknowledged their lifespan is 10 to 15 years in the body. This is the black box warning that came out last year in September, where they clearly acknowledged the fact that they're meant to be replaced every so often. I say 7 to 10 years. I did a lady that had implants removed that were inserted in 2019. Just 2 years later, she just felt and truly was convinced that the implants were hurting her from the very same day that she got the implants. And the second thing we know for a fact that the implants only hurt the body. The implants only tax the body. It basically cause the negativity that the body goes through. No one will ever walk into my clinic or any clinic in the world and say, well, my implants are making me better or they make me feel healthier. Absolutely not. If anything, the implants only hurt the body. And this is consistent again with the FDA black box warning, which clearly states that the implants are meant to be in the body on average for 10 to 15 years. Number 2, they're associated with breast implant-associated anaplastic large cell lymphoma, which is a form of cancer, not only in the textured implants, but also the smooth. And the FDA also acknowledged that there is what is the breast implant illness, and that if the patients do get this, is part of the informed consent that they need to bring this to the attention of their plastic surgeon because their body is reacting negatively. Now, I've been asked this question many times before. This fact alone should tell the potential patient who wants to get implants that the implants are not safe. Imagine, we live in the Motor City here in Detroit, suburb Novi, Michigan. Imagine you're about to get a house or a car. In this case, you're about to buy a car, and the manufacturer tells you, well, this car has been noted to last only 10, 15 years. It may break down, or it may give you this trouble, or this percentage of the people are noted to have these problems if they were to get this car, or let's say if you were to invest in a house. No one is going to ever buy it, and this is precisely the point where I say the implants are not worth it, amongst the many other reasons. So going back to the 5 criteria that I say that ensure, that confirm and authenticate that the surgeon, from my experience, this is not being well defined, but I will tell you, and this is all common sense, if you will, if I may. Number 1, the length of time it takes for the surgery to be done. It should be on average 4 hours. Yesterday I did 2 cases and I got done approximately 4:30 p.m. and this is where I started approximately. I made incision a little bit after 7. The point here is it takes time to do the dissection, and remember, majority of the implants are below the muscle, and the dissection in itself off of the rib is a very tedious, sophisticated, meticulous dissection where you cannot rush into it. And that in itself is a 4-hour commitment that I have with all my patients. And this is exactly what the consent form says. And the consent form is the legal bind between the surgeon and the patient, where they know that the surgeon is going to do the right surgery. If your surgeon books the case for an hour, you know, I will tell you with absolute confirmation that that is a patient who is not going to get the correct surgery, because I would love to do the cases in an hour and do 7 or 8 in a day. Now, having said this, number 1, the length of time, approximately 4 hours. Number 2, the length of the incision. You cannot remove an implant through a 3 centimeter or small incision. The diameter of the implant essentially dictates the length of the incision. Number 3, the implants need to be returned to the patient, which is an integral part of that. The implant was removed definitively. It was removed intact if it was a saline or even a silicone, and then the patient gets to match, at least with her card, that this is exactly what she had. You will be surprised, and I have been surprised that many times the patients have come and they said, well, I was told I'm going to have saline implants and silicone implants were removed, or I was told that there was, and these are my patients from my Facebook Live and the many other patients who have come forth, that the card did not match what was the lot number on the implant, or one implant was one manufacturer and the other implant was another manufacturer. Another patient was told that she was going to get silicone implants and she ended up getting saline, and vice versa. There's a patient I did at the hospital, believe it or not, she had silicone on one side and saline on the other. The fourth thing is the pictures of not only the chest wall, but more importantly, the pictures of the rib cage, if it's below the muscle, also all the way up, showing that, preferably a video. This is a video that I do on all my patients that basically looks at the entire chest cavity, showing clearly that the chest is void minus the capsule, so that the patient knows with certainty that the entirety of the capsule was removed. And that not only of the chest wall, but also on the table where you have the implant and the capsule encased as one system. Last but not least, and probably the most important, is the reputation of the surgeon. I myself have a reputation online, within the community, within the hospital, and we established over the years, just like a restaurant owner would, or anyone, for example, a lawyer, or an engineer or an architect. You know, we all have reputations. So it is important that, number 1, the surgeons openly discuss and accept the fact that breast implant illness exists. I would never go to a surgeon who says, I don't believe in breast implant illness, and that they would do a end block resection, because you cannot say, you have to first acknowledge openly that breast implant illness exists. If you cannot, that means you will never accept that you're going to do the right surgery. You have to openly declare and happily accept the fact that breast implant illness indeed very much exists. Now, I want to go ahead and talk about how I do it very briefly. As you have seen on my Facebook page, there are a few things that I do differently amongst the many other explant specialists. You know, there is no textbook, there is no journal or any article that has been written that describes exactly what it is. You know, if you go to a hospital that is associated with 1,000 doctors, family medicine, the specialists, the rheumatologists, the pulmonologists, you will find that the vast majority of them will accept the fact that the implants are safe. If you go to the top 100 hospitals of the US and you complain of what you have as far as breast implant illness, you will find well over almost all of the surgeons will accept the fact that it is time for the old set of implants to be removed and that a new set essentially replaced, which is certainly not the right answer because the patient is suffering from breast implant illness. The answer is the patient should have removal of the implant and capsule such that they get a bounce back. Now, about in regards to how I do the procedure, number one, why I do what I do and how I do it differently. If you look at some of my YouTube videos, especially the one that I put forth 4 or 5 days ago, you will see how I dissect off of the chest wall, off of the rib, which is indeed the hardest part of the whole case. The dissection up on the superior aspect of the chest is also very important, and the entirety of the surgery is actually very, very sophisticated and delicate, and only when I do make the cut do I realize the intensity and the challenge of the surgery itself. One side may be relatively harder, the other side may be easier on the same patient. A patient may have a contracture on one side and maybe a normal physical exam on the other side. And a capsular contracture is basically where you have the capsule in itself gets hardened, compresses against the implant and against the chest wall, and essentially distorts the chest. If there is no pain, that is called capsular contracture grade 3. And if there is pain with distortion of the chest wall where the implant is riding high or laterally, or physically distorts the chest with pain, and that is the highest of the capsular contractures, which is called grade 4. So you can go ahead and actually Google this, capsular contracture, Baker's classification, class 1, 2, 3, 4, and you will see the 4 different types. Now, having said this, number one, the many things that I do differently, overall 7 that I say that I, as an explant specialist or an en bloc specialist, what I find is critical or crucial. Now, one thing I may mention is, you could be the world's best microsurgeon, but if you don't believe in breast implant illness, the entire validity or the authentication of that surgeon is essentially lost. Same thing, you may be operating for 20, 30 years, but if you don't believe in breast implant illness, you don't believe in that the entirety of the capsule must go, then the entire validity or the entire the way of how the surgeon does it is basically certainly very much questioned. So it is not the length of years of the training, it is the best example and the best reassurance, the best peace of mind that any patient can get. And this is, again, logic, basic logic, is to look back at the old patients that the surgeon has done so that you can relate to them and say, you know what, I'm going to be part of the same group if I were to choose that surgeon. And I humbly request all explant surgeons to come up and have a discussion with their patients, be it online or in person or over the phone consultation, such that the patients understand what is in the surgeon's mind, how and what to think of. Are they still augmenting? Are they still implanting? Because that all of a sudden questions the fact that they don't believe in truly breast implant illness. And breast implant illness ultimately afflicts every single patient, because remember, the implants are not meant to be in the body forever, and they have a certain lifespan, be it short, 7 to 10 years on average, maybe less, maybe more. And that ultimately all patients will eventually succumb to what is breast implant illness, because they're not meant to be in the body forever. Be it a rupture, be it a contracture, be it the breast implant illness that may affect them, and maybe it might be variations of the breast implant illness that in certain parts of the year, depending on the weather, it might be less severe or more intense, and one symptom may come and then may never come again. And as we will know, we need to do our due diligence, the homework, through the primary care doctors, so they have been seen by the rheumatologist or the primary care doctor or the endocrinologist, the cardiologist, the pulmonologist, the allergy immunologist, the gastroenterologist, so that we have ruled out all those potential problems, such that when you come to me, breast cancer has been ruled out. If there's any irregularities noted, such that when you do get the surgery, we can say with reassurance, by default, this is basically what we're looking at. We may not have a true, frank lab diagnosis. We may not have an imaging diagnosis, but what unites, or basically what reassures what is breast implant illness is a young lady or an elderly lady that basically has those many check boxes in the questionnaire that I ask all questions, where you can see the many different organ systems are affected, from the vision to the headache to the neck, back pain, to the sinus problems, to the nasal drip, for example, the fibromyalgia type symptoms, chest pain, shortness of breath, palpitations, rheumatological joint issues, blood pressure, amongst the gastrointestinal issues, and plantar fasciitis, the connective tissue disorders, the rashes, amongst the many other organ systems that the breast implant illness touches. Now, going back to what I was saying earlier, so I, as a board-certified plastic surgeon, what do I do differently? Number one, as you will see, I have a whole series of patients where I have not used drains in patients. So this is very clear. If you go to my YouTube video that I just put out 4 or 5 days ago, you will see the dissection. This is essentially the bloodless field, no indication for the drainage tubes. And many people have asked me, including plastic surgeons, and I essentially find that avascular plane, it's essentially a bloodless plane directly on top of the capsule, where I take my time to dissect very smoothly, laterally, deep, posterior, superior, such that the entirety of the implant is removed along with the capsule with essentially 0 or like 3 or 5 cc's of blood loss on average. So no need for drains. Number two, vast majority of the patients do not need a lift. That's approximately 80% of the patients. Just this past week, the last week, I saw a patient 68 years of age, and she did not need a lift. And that in itself, I was very much surprised that given her skin, the elasticity of her skin, the sun damage over the years, she was able to bounce back to what would be a very aesthetically pleasing chest, status post-explantation. Again, there's so many variables from genetics, but still many patients, 80% of them, do not need a lift. Remember, the entire surgery, in vast majority of the patients where the implants are below the muscle, the 4-hour commitment that I have is all below. The lift, or the mastopexy, which is the better term, is all above. That in itself is a 3-4 hour operation, and it just baffles my mind how some surgeons are able to do the end block, which is all below the muscle, and they're able to do the mastopexy in what would be a 3-hour time, which would normally take me approximately 6-7 hours, and where it's not even required, as you will see. And I tell all my patients, let the skin settle, let the breast tissue settle, let the inflammation settle, and maybe a year later, if you certainly choose to, which majority of the times you may not need to, if you certainly do desire, then go ahead and get a lift at that time. Absolutely, I'm not saying that no one needs a lift. There are patients who need a lift, but do not commit to a mastopexy or a lift at the time where the whole essence, the whole focus, the whole gist of the surgery should be to do the best end block, the total 100% capsulectomy, such that 0 inflammation remains behind, such that when the surgery is done, the patient and the surgeon can say with reassurance, this was the best surgery the patient got. If they were to go back, they could not say, well, I wish I had removed that, because that is the last thing you want to hear. So number one, no drains. Number two, no lift. Number three, I 100% of the time return the implants to the patient, because they should see there should be a definitive psychological closure. They should match the cards. They should make sure that this is indeed how it was removed intact, if it was saline, and even with the silicone, as to what the content was, so that they know what was removed. Number four, I send 100% of the time the capsules off to pathology. We need to know what was that capsule, why did it cause all this havoc and the destruction and the detrimental effects. We need to make sure there is no BIA, the breast implant associated anaplastic large cell lymphoma, no signs symptoms of breast cancer, which has also been associated with some capsules because it was noted to be in the proximity of the breast tissue, abnormal pathology, malignancy, amongst other factors such as the giant cell reaction, the refractile foreign material that we know on the pathology reports. Also, I take microbiology cultures from the chest once the implant is removed. where I do cultures for aerobic, anaerobic, and fungal cultures, again making sure that there is no bacteria associated with the implants. And as we know, sometimes the capsular contracture is associated with bacteria, so at least we have ruled that out. And the next thing is the twilight sedation that I use, which basically means that this is the monitored anesthesia care. The patient is essentially breathing on her own. She is not paralyzed, she's comfortable. It's very effective, very safe anesthesia. And as you will see now, to date, not a single patient has come forth and complained about the anesthesia where they heard they're in deep sedation, they have no recollection of what happened, and an anesthesia that they bounce readily back to what would be a good post-op phase and recovery and ultimate discharge. So again, these are the very important aspects. I heard another patient went to a surgeon and she was told that she was going to get drains for 2 to 4 weeks, and I find that that is absolutely I use the word bizarre, how and why someone would have drains for that long. And the only reason that would be if there's cut into the muscle or there's residual inflammation that is left behind that will continue to produce fluid. And this is what I would say is a big red flag. Another thing is if your doc says that the insurance is going to cover the procedure, that automatically 100% is a red flag. That is basically a warning. The insurance reimbursement rate is essentially minimal to none. That will not justify the surgeon spending 4 hours. Most of the surgeons don't even believe in what is breast implant illness. And I assure you, if you look and read from what you have just heard right now, with all due respect, this is not what I would call the proper explant, i.e. in the end block that you would be getting, or a total capsulectomy. Now, having said this, I'm going to go ahead and kind of scroll down and look at some questions. Now, one thing that I want to show is, at the end of the day, what I want the patients to do. There are some patients that have literally studied breast implant illness for years, like a year or 2 or 3. I jokingly say when I meet these patients that you have a PhD, you could get on the board and give a lecture on what is breast implant illness. And it is very, very comprehensible. If you listen to my Facebooks and the videos and you follow through, you will be able to see what exactly I talk about. There's tutorials or small videos that I have done on what is a total capsulectomy, partial capsulectomy, capsulotomy, or what is an end block, amongst not only I, but the many other surgeons. And you should be able to feel comfortable, ask the right questions. You should, just like everything in life, you should be in control. You have your rights. You want to be comfortable in asking those questions and content. And again, I find the most important, valuable tool that you have is the surgeon's previous patients who can attest to and confirm what and how their journey will be, such that you have the confidence in your surgeon. And you should have a dialogue. You should have that confidence in your surgeon. It's a very big deal surgery. It is not small. This is what I say. Excuse me, the sensors went off. Just 1 second. Sorry, we have sensors in our office. I'm still in the office here in Novi, Michigan. So the point I was trying to make here is you should have that confidence with your surgeon, where you need to have that commitment from your surgeon that every single time your surgeon goes to the operating room, that the 100-100-0 rule is applied, which is 100% of the time, 100% of the capsule is removed, with 0% of the capsule remaining behind, because this is where your bounce back is. And this should be very clearly stated on that consent form, because that's that legal bind you have with your surgeon. Because you don't want to say attempt, or I will decide, and I will see, I will do my best. I removed as much as I could when I did the surgery. These are not good answers. The last thing you want to do is basically to get the surgery and to go through the physical pain and the financial burden of going through the surgery, only to find out that you need to get a secondary surgery to remove the residual capsules. Now, I want to go ahead and the bottom line is your surgeon should fight for this. And there is ample evidence. Look, we know from another post by one of the other sister support groups on Facebook that the FDA had at least 350,000 complaints against breast implants that they basically knew of. And if there's 350,000 complaints, I can assure you that there are at least 350,000 that the ladies did not submit. So the most important thing we can do is talk about what is breast implant illness, write about your experience. I personally, I'll tell you, it is hard for me to talk about implants and what I do that is strictly as a board certified plastic surgeon, not having put in implants, just putting in one set in my entire career and deliberately, purposefully not putting them in, and to talk against augmentation, where vast majority of my colleagues basically question and ask, and these are my friends who basically kind of look at me differently, and I say, what, at least in my mind, heart and soul, I'm doing the right thing, because ultimately the patients are improving, they're benefiting, their lives are changing for the better. And what, that is exactly why I became a doctor, and I request and humbly request the rest of the doctors, the surgeons, to basically look into what is truly a movement, such that the patients talk and they basically enhance the other patients' experiences and basically bring awareness to the many other doctors. I have a patient that I just took care of from Nevada. She texted me that she already let her doctors at the Mayo Clinic and her primary doctors and the other doctors know exactly what and how and what basically she went through. There's another patient that she is going to let her doc see the videos of what I have done, such that they learn on what is breast implant illness. As I will mention, and I did mention on the last Facebook page, there was a patient that went to the emergency room, and lo and behold, she got a CT of the chest because of the shortness of breath. And the emergency room doctor told the patient, well, I cannot write this as a diagnosis because it truly doesn't exist, but I strongly feel you have BII and that you need to go see Khan, so that I strongly feel that that is what you're exhibiting. This is exactly what we need to do. There's another physician from Florida, Gainesville, who basically reached out to me, and he was a primary care doc, and he asked me, how do you want me to prep for these patients that will come and see you so that they can get their explant done? And this is exactly what we're talking about. We're raising awareness in a very nice, humble way, so that many patients who have not even heard of this, they learn and they basically put the two and two together and get the help that they very much need. So the many women who have had bilateral mastectomies with implant reconstruction request aesthetic flat closure. Absolutely, that is the only way to close, where the patients have had their mastectomies. Even if they had nipple sparing mastectomies, the goal is to remove the skin paddle in the form of an ellipse. And then you will, if you look at my YouTube video, I remove the ellipse such that when I do put the flap together, it's a tension-free closure, nice aesthetic. Now there are dynamics of the chest and the muscle as a result. On the table, when I get done, the closure majority of the times, it's nice and smooth, which continues to persist. There are some subset of patients where, because of the muscle movement, the animation, that wrinkles, indentations form, not only in my patients, but the many other patients who have had flat closures who chose not to get implants when their breast surgeon closed them. They were nice and flat, but eventually over time, indentations do inevitably occur, which can normally be fixed with fat grafting or excision, but they are a dynamic part of the skin as a result of the muscle, which sometimes do occur even in the cases that have had a flat closure at the time of the surgery. So what do you mean by avascular plane? Avascular plane, this is true basically where you're dissecting, the surgeon is dissecting not only in the explant world or end block, where the dissection occurs in the fascial plane where there is no blood, so that you don't eat into the muscle or you don't eat into the capsule, such that you're in that nice fine division. And if you look at my YouTube video that I put 4 days ago, you will see the dissection where you have the connective tissue in between two structures into which the dissection occurs, such that there is no cut in the muscle or there is no cut in the capsule. Avascular plane is a plane where there is no vascular tissue or no blood vessels, and this is where you have, for example, the gallbladder is stuck on the liver, and so when the surgeon dissects the gallbladder off of the liver, they are in that avascular plane such that they're not cutting into the gallbladder or they're not cutting into the liver, and it's that very nice thin film of connective tissue that kind of holds the two together. That is that avascular plane. Now when so we find this is a very heavy question. As you will see in the many patients, when I do remove the capsule off of the rib, which is the hardest part of the whole case, and as you will see in the many patients who I've given the videos or that, and you will see on YouTube, the fascia of the intercostal, which is directly on top of the rib, and the intercostal is physically removed, eliminated, deleted, physically excised off of the chest such that you have no capsule remaining behind. Otherwise, the capsule inevitably remains behind, and that small amount of capsule that's left behind will continue to hurt and trigger what is the breast implant illness. And so it is integral to remove that, and this is where the sophisticated, delicate surgery comes into play. Now, do you fat transfer when explanting? So I will say this absolutely 100% bad idea. Fat grafting basically means you take fat, usually from the belly or the thighs, wherever you have access, spin it, and you take the nano fat or whatever good fat that there is in what is the Coleman technique, and you process. So let me give you an example. On the face, where you have the best blood supply, if you inject fat, majority of the, and we're talking about 3, 4, 5, 6 cc's, not much, small amount. 30% of the fat dies where you have the best blood supply, and you web it out, you spread it out in a fan it out, if you will, such that it spreads evenly, because you want that fat to take by the blood vessels that will supply each individually. Now on the breast, if you can imagine, you have that big void where the implant was sitting, plus all that inflammation. As you will see, the many ladies who have implants, the dilated, engorged veins, the green veins that they have, this is all the inflammation. If you inject fat there, let's say 100 cc's, I assure you with confidence, on the face 30%, on the chest, let's say the best case scenario, 50% of the fat lifts, the 50% dies, and now you have clumps of fat that you're going to form. And I assure you that is something that is not going to take. And later on, when the patient gets a mammogram, or 6 months, a year later, when she feels her chest, she's going to find irregularities, fat necrosis, and that is going to be a major problem, because it will be a question mark if this is breast cancer, if this is fat necrosis, if this is normal findings. And I have patients, unfortunately, an active patient of mine, she explanted, believe it or not, which is what I would classically call a malpractice case. This lady, she had breast cancer on the right side, she had a lumpectomy, and she had radiation. So this is one option she chose versus a mastectomy. Now she had a big void, a divot in her chest. Her plastic surgeon chose to do fat grafting and on a radiated field, and also put in an implant. Now, as you can imagine, she had fat necrosis in a radiated field. Post-explantation, you can only imagine, and this was above the muscle to kind of add to the complexity. So now all of a sudden you have an indentation with irregularity on the chest, and now, given the history of breast cancer, there is concern on a mammogram, and now on the MRI, is this breast cancer or not? And now there is anxiety, as you can imagine, in the patient's mind. What should she do? Plus, having explanted, the post-operative challenges of how the wound is going to heal. And the point here is, fat grafting is a very dangerous process. It is incomplete. Sounds good, but in reality, it is not a smart idea, and it is a very, lack of a better word, foolish move, sorry to be blunt, where it will only hurt and haunt post-operatively, and even 100 cc's is not much of a volume that should be worth entertaining, given the badness that it causes. Now, do you do any surgery on the pectoral muscles? Now, one thing I want to mention here is, and this is what I did on the last Facebook Live, but I'll go ahead and do it. Now, my best patient, who's my best patient? My best patient is the patient who has saline implants above the muscle with a contracture. Why? I know if she has a good exam, her saline implants are not ruptured. Number two, they're above the muscle, so my dissection is going to be easy because it's not on top of the rib, it's on top of the muscle, it's below the breast tissue. And number three, it's a contracture, which means it's a hardening of the capsule, which means that when I do make the cut, it's something hard, like an eggshell that I have to hold and kind of relatively dissect with ease. And this is one of my patients, like famous NBA player's wife, that I basically took care of. And it was a very easy, nice, smooth dissection, and one of the easiest ones that I have done, because this is exactly those three things that she had. My hardest one is the patient where has a ruptured silicone implant from the 80s or the 70s, which I've done, and I've had to remove in an en bloc fashion. And this is where 6 hours, 6.5 hours later, I was able to remove it tactfully. And this is my toughest case that I would do, where it is deep within on a lady that has a high BMI, for example. So those are my toughest patients. Now going back to the pectoral muscle, now I will tell you what I want to do is I want to show you on my other phone what is the pectoralis muscle. The pectoralis muscle, as you will see right here, is the muscle that sits on the chest. The insertion point here is on the humerus, and this is what I tell the ladies, the pectoralis muscle. You want to do the pectoralis muscle is the active muscle underneath which the implant is placed. So essentially what I do is I make a cut right at the base right here, and I access what is the implant underneath this muscle in that avascular plane that I was talking about. And so what I do is, what do I do to the rest of the muscle? I leave it alone, because anytime I touch the muscle, it's going to bleed. And plus, whenever you repair the muscle, you can never repair it. So why touch the muscle when you can make a cut right at the bottom right here and access the entirety of the implant and leave the rest of the muscle alone? Sometimes the muscle attenuates or softens and thins out. Sometimes the surgeon, the initial surgeon, cuts through the muscle and it may retract up, and it depends on who did the initial surgery. And I can tell a lot when I do the surgery as to how good who was the initial surgeon who augmented. And as you will see, it inserts into the humerus. So anytime you contract the arm, you flex, you inevitably tighten and move the implant. So this is the reason behind the T-Rex. So if I don't cut the muscle, I don't need to repair it in the vast majority of the times. Now imagine those patients that undergo surgery where they go up and down incision. You can only imagine that the cut is going to be made on the muscle, even if it's made sideways. Let's say the surgeon places the implant through the nipple, which a lot of patients have had that. Imagine then the surgeon has to go through the nipple areola, they have to go through the breast tissue, they have to go through the muscle, and then underneath which is where the implant is. In this case, I always make the cut at the bottom. I hide the scar, and I do not cut the breast tissue, I do not cut the nerves, I do not cut the ducts of the nipple areola, and I don't distort the anatomy. I don't put a scar in the center of the chest. And last but not least, when the patient gets a mammogram, it's not going to highlight or pick up on any abnormalities. And so that's why I leave the muscle alone. Just make a cut at the bottom, access the implant, and call it a day. Go in, take care of business, come right out. Don't touch the muscle. And this is where, again, at the very bottom right here, this is where that can be accomplished successfully. So hopefully that answers your question. All expanders were textured in 2012. When I had bilateral mastectomies, I had mentor expanders. Any relation to LCL? Now, what is interesting is if you look at, the textured implants classically have been associated with the textured implants have been classically associated with BIALCL to the point where France banned the textured implants, and the USA soon thereafter told Allergan to go ahead and ban or not make any or sell any textured implants. So any plastic surgeon who places textured implants in the US will have their license revoked. Now what's interesting is, and then again I will say it's probably amusing, living in the Motor City, if there is a, hypothetically speaking, and I'll use the car example again, if there is a problem with faulty airbags, right, on a car that was made by Ford or GM or Chrysler or any manufacturer here. What do? They say, bring the car, we'll free of cost replace. Now, in this case, what happened was they said textured implants are associated with lymphoma. We're banning them. But guess what? If you have textured implants, live happily ever after. So there is no recall. They just said, Allergan was told by the FDA, please send a letter to your patients, i.e. the clients who got the textured implants through the plastic surgeons, and that there's a moral obligation in letting them know that this is basically what they have. But they never mandated any insurance companies, medical insurance companies, or the doctors to have these patients go to their respective plastic surgeons or any plastic surgeon and get them removed or replaced. No, there was none. So there's no recall. But now the other thing I want to mention is not only with textured implants, we know smooth implants are also associated, but to a much lesser extent, hence no ban on those yet. Now, I do not know what the association is with the textured, but it was very trendy at one time where a lot of surgeons were using the textured implants, and then all of a sudden the trend was no more. Can I ask, why aren't the other doctors taking out all that inflamed breast tissue? Now, I'll tell you, this is something where the other doctors need to learn. You don't want to leave any inflamed tissue behind, because remember, we have seen the many patients where the inflamed tissue is left behind. This is where there might be a microbleed of the silicone, or there might have been a focal rupture or a leaching out of the inflammation or that silicone mastitis because of a result of the silicone. And if you leave that behind, that burden remains behind. So by visualization, by palpation, by visualization, what I mean to say is that the fat has a dark gray consistency to it. It does not look healthy. I remove it because you want to err on the side of caution. By physical palpation, by the fingertips, the texture, the dexterity. Look at the many Facebook Lives where I say, you hear about these many other, quote, Facebook owners and say, well, I analyzed by picture that this capsule was much thicker than what I would want, so I don't approve. That is not how someone should judge. You judge the capsule by physical touch. You judge the capsule by, for example, you hear when you cut how thick it is, and when you feel and palpate, and by visualization, what the texture of the inflamed tissue is in the proximity of the capsule. Yes, it is awesome and brilliant to see a paper-thin capsule, but you don't want to be leaving that inflamed tissue behind, because remember, the silicone is leaching through. We know this because remember, it's in the lymph nodes on the many patients. Remember the many patients who have biopsies of the lymph nodes and to say the refractile material, this is giant cell reaction, foreign body reaction consistent with what is silica. Remember Dr. Mowers, the pathologist who has looked at lymph nodes, who basically in those patients where they had palpable lymph nodes, in those patients that had ruptured implants and the silicone migrated to the lymph nodes. And this is precisely that same cadaveric study where the lymph nodes and the nervous tissue, the connective tissues were looked at and basically looked at under electron microscopy and also energy dispersive x-rays, and they concluded there was silica basically spread out. We also know this from Dr. Atul Mehta, who was a guest Facebook Live from the Cleveland Clinic, who's basically clearly in his physical hard evidence pathology / electron microscopy and energy dispersive x-ray analysis concluded definitive certainty that silica was present within the lung specimen biopsies that were done on the patient who had saline implants, both of which were intact, not ruptured. And again, so there is overwhelming evidence that all this inflamed tissue should go. Now imagine, look, when we have this COVID vaccine, right? Small fraction of a cc is injected, and that in itself is enough for the human body to impart an immune response such that if we do get exposure to COVID, guess what? That small amount of cc that was given has re-energized our immune system so that we can fight off any COVID, even the variants. Now imagine you have residual silica left behind. that in itself will continue to trigger, haunt, and hurt the body. And this is exactly why all inflamed tissue must go. If I am ever on the fence and decide, should I take it or should I not, I always remove it. Now, I will say this very bluntly. You know, one of my plastic surgery colleagues said, oh, your incisions are too long. I said, you bet. I want to remove everything safely. I want to remove everything definitively. I want to physically visualize and make sure that I'm removing everything in a safe way such that there is no problems, that there is no bleeding, and that I remove it definitively. Sometimes you make an incision at the bottom of the chest and you have to go all the way up because of the capsular contracture. So you bet my incisions are big, but I try to hide them, and I hide them very nicely at the crease, because the goal of the surgery is not aesthetics. The goal of the surgery is to make the patient physiologically better. This is essential surgery, and this is as non-cosmetic as a surgery as non-cosmetic can get. Los, what I'm doing to the patients, and this has been proven last year, you know, at the Canadian border, which is right here 30 miles away, the border patrol agent called me and said, literally, I had a conversation with the border patrol agent and said, why is this lady coming to you? You're a plastic surgeon. We have plastic surgeons in Canada. This is not essential surgery. She's going to get plastic surgeon. I said, sir, go to my YouTube channel. Please have a look. And I want you to go ahead and see for yourself what I'm offering. And lo and behold, 30 minutes later, he literally called again and said, your patient's coming through, good luck with the surgery. Because he knew, and I explained to him, I'm not doing any cosmetic surgery. I'm doing essential surgery. It's required for the benefit and physiologic benefit of the patient. And last year, there was a patient that I took care of 9 o'clock Monday, which is when the entire hospital, the OR system was shut down and they were doing only emergencies. Even patients that had rotator cuff tear or meniscus tear, you know, the orthopedic hip procedures, those orthopedic surgeons were told you cannot operate because those are considered elective. And lo and behold, the operative committee here at the hospital said, Khan is doing what is essential surgery. I was getting the prime time 9 o'clock, like I said, and I was doing what is the essential surgery, and this is the least cosmetic because this is for the benefit of the patient. And having said this, yes, I'm removing the volume. Yes, because the goal of the surgery is to delete all those check boxes that the patient come in with, so the patient bounces back and is healthy, is better, back to enjoying life again. And you know what? Later on, if we have to, we can always take care and address this from a cosmetic level. You don't want to be manipulating, moving around what is inflamed tissue, or one patient may have engorged dilated veins or tissue that is basically reactive. And, you know, the goal of the surgery is to offer the patient relief. And at the same time, as you have seen, the many patients who come forth and convincingly say that they do not need a lift because the surgery, the way it was done. And the way I explain this is, imagine in the vast majority of the patients where the implants are below the muscle, you have the nipple areola, breast tissue, the muscle, the implant, and the rib. When I remove the implant and the capsule below the muscle, what happens to that bottoming out of the breast tissue? It essentially, because of the compression and the binder, which is an integral part of the postoperative phase, it essentially falls back up, and essentially the pectoralis adheres or sticks to the rib, and as a result the patient ends up getting what is a pseudo lift. Because the dissection is done in a very nice, meticulous, millimeter by millimeter way, where there is blood loss is minimal, there is patients less pain, there is better preservation of the aesthetics, there is no breast tissue that is touched, no nipple areola tissue that is touched, and the patient gets a nice healthy bounce back with less pain and a better aesthetic result, if you ask me, versus making the up and down and all those other incisions, which I will say to you are unjustified and uncalled for, and too much surgery on a day when the whole focus must be and should be the whole end block in the perfect manner, or 100% total capsulectomy with no need for drains. And that is what I will say. The no need for drains confirms in my mind as a surgeon that the surgery was done right. Imagine you leave the inflamed tissue behind. It's going to weep and it's going to ooze, and you need to have a drain for that. You know, you hear the many significant other, boyfriends who would pull drains, which I find is a malpractice. You know, only the surgeon must be pulling the drain because they're the ones who placed it and they need to remove it when the time is right. Having drains is not safe after a period of time. The drains are very much required when they're very much required, but not should be the standard of care when the surgery can be done very safely and effectively without the need for drains. Now, I will tell you this. We have a momentum. You know, I see Tracy Gary every time I see her name and I say, you know, this is a nice, noble lady. She's done a lot of good. I'll tell you, ladies, you know, the black box warning is a big step, a big benefit for us. You know, this is where, you know, the FDA clearly said, you know, and hopefully this passage by Tracy Gary and the many other ladies, Miss Pugh, who was here, we did the Facebook Live where we hopefully passed legislation here in the Lansing, the capital, where any lady who wants to get augmented gets to sign that, you know, she understood and understands, and this is part of the informed consent. And this is where Miss Clifford from the Channel 7 News basically brought this news forecast, or the news that, you know, we need to alert all prospective patients who get implants such that they understand that the implants are not meant to be in the body forever. This is what the FDA said. We want every patient to highlight this before they accept the detrimental effects of the implants. Number two, the implants cause cancer, and the textured implants especially. And number three, that the implants have what is the breast implant illness. So keep talking, keep writing. You know, I do not want to be neutral and be politically correct and say naively, I want to just talk about breast implant illness. I will tell you, I want to talk about breast implant illness, and I want the implants banned because that's exactly where these implants belong. Why should the patients hurt? Why should the patients suffer, and not only the patients but their significant others, when we have overwhelming evidence that the implants only cause harm? And look, there is such a big momentum. I want each and every single patient, if you certainly can, talk, write, and discuss such that the many other ladies hear about it, and that those ladies who do not know what's wrong with their body and their system, they know that there is a real problem, a real entity with a real solution, such that they get their life back. You know, the bottom line here is, you know, we will win this, I guarantee you, because we're talking in the masses. Look where we were 5 years ago. Look where we are now, 2 years, you know, later from the ban, and then last year's the FDA black box warning. You know, the fact that it has shown up, and now documentary, movie after movie, the patients are talking about it. There is a momentum. The news journals, the media, the ladies are talking about it. There was a big symposium last October, you know, and again, we need to have more of a discussion with the primary care doctors. You know, one thing that I want to mention, this one nice lady that came from Brooklyn, New York, I don't want to mention her name. She told me one thing. She said, every single time that you post a video or a testimonial or a pathology report, please, and I said, you know, now she said, I read it every single time, and that's what gave me hope. And I said, wow, that's pretty strong. Excuse me, please. I'm going to go ahead and move again so I can get these lights on. So I make it a point where I want to talk and write about each and every single one of my experiences, be it in the OR or the pathology report or how the patient bounced back, such that we have what is this proof and hopefully studies that will be done. Now, what I want to do is just kind of a little bit, I'm a biochemist in my undergrad training from UT Austin, and I'm a Longhorn. And so what I want to do is, you know we have the saline implant that leaches out what is the silicone. We know that from Dr. Atul Mehta, and we know this from the many patients who have had the similar symptoms of what is silicone. The answer lies within what is the saline. So what I am going to do is I'm going to reach out to my colleagues in the biochemistry department, mass spectroscopy, and I'm going to reach the same lab in Buffalo, New York, where I'm going to analyze, spin, centrifuge that saline such that the heavy metals sink down in what is the normal saline. Once I've collected that, I will know whatever has been leaching out in the bloodstream is certainly concentrating within that saline, such that we can study that saline better and we can see what is in it, such that hopefully, and thinking out loud, that we can connect what is within the saline, those heavy metals, and one day we can use that and extrapolate that knowledge to do blood tests and see how and in what capacity that was affecting the human body in the negative way that it does, such that we will be able to quantify that one lady that walks in and says, I have all those check boxes, or another lady that comes in and says, well, I have only 3 boxes that I checked. Now that way at least we'll have a way to grade and very objectively quantify what is breast implant illness, and at least have a very soon a ICD-10 code, so the many ladies who spent and basically do these GoFundMe pages, which I will tell you is their lifeline to what is the freedom from breast implant illness, so that the government, just like they did with COVID, pitch in and they contribute to basically what would be a successful explantation. And my goal here is, no one taught me how to do an explant or an block. We never learned this. I've gone to all these major medical centers, and if I were to go with all my patients to all these reputable, phenomenal, world-class, the standard of care and standard of excellence, you will still get the same answer. We'll go ahead and take the old set out and replace them. And again, this is what I said earlier on in the Facebook Live. The take-home message here is the entirety of the implant plus the capsule must be removed as one system, such that the entirety of the burn is removed, such that no inflamed tissue is left behind, such that the patient gets a bounce back to their normal good state of health, such that they regain their health minus the toxicities that are imparted by the silicone. Please be on the lookout for, I have released so many videos. Now what I'm planning on doing is many more that I have that I want to show how I do it, why I do. I thank my many patients who basically, and again, for me, I'm going to continue, I tell this to everyone. We had a University of Michigan student that came and he's interested in pre-med. Actually, another student that came last year, I found out a month ago that he got accepted to medical school. Hopefully he'll follow in the same footsteps. And I say this to everyone, and I'll end with this note. In order to do anything in life, we need 2 things. Number 1, do it honestly, from the heart, from the bottom of your heart. Like if you were to look back and say, you know what, I could not have done a better job. Like literally, sincerely, with respect, with care, with the sophistication. Like you basically, you're not like a number, or you're not like another case. It is the same thoughtfulness where, it's a mental game. If you ask me, it's like when you run a marathon, it's not the physical act of the marathon that is important. That certainly is, no, don't get me wrong, but it's the mental game, what you are thinking and how you are thinking. And surgery is very much like that. You're like at the top of a ski slope and you're going to jump. If you're not 100% sure you're going to get the whole capsule, you're going to end up on the face and you're going to break your neck and you're going to hurt the patient. If this is basically what I can use as an analogy. And this is where, the surgery is a very big deal. It is a serious surgery, and it is an involved surgery. So the 2 things that anyone needs, number 1, are 100% sincerity, honesty, the dedication, that faithfulness to the patient, the bond, that the only thing that matters is the patient's well-being. Number 2, which is hard work, which is basically an integral part. Now, obviously, what comes into play is the intelligence and over time. And I'll tell you, we all are intelligent. We all know if you bring in a physicist or a librarian or someone who works, basically a non-medical job. We all know intuitively this person knows what he's talking about. This person is basically, this is the right thing, this is the right aspect. And I know this from the many ladies that have come from all walks of life. Many of them are not in the medical field, but they have studied this enough. An accountant, for example, she can tell by looking, or an ICU nurse, what is the right thing. And I say this to you, whatever you do, and I say this to the many ladies, you know, they're so nice and thankful, and we see them as soon as they wake up. And I say, you know what, if each one of you were in my shoes, you would have done the same, you know. And the bottom line here is we need to make this world a better place. And, you know, this is where I tell the rest of the docs, you know, there is ample evidence, there is overwhelming evidence that the implants are bad, they only hurt the body, and that we need to acknowledge, and we need to offer this relief to the many patients who are desperately waiting, so that we can make this world a very, very good place, a better place, and that we strive for that time where, you know, we can say we did the best, and we look back and say we could not have done any better. Having said this, thank you so much, everyone, for watching. Till we meet next month. What I'm going to do is, you know, I thought about, if you have some ideas, you know, we have had a pathologist, we have had a cardiologist, we have had other patients that I've interviewed, you know, basically what they were thinking, what was in their mind. You know, I've thought of basically doing kind of like a mock consult with someone, you know, as to what goes through my mind as I ask the patients. You know, there's a lot that I discussed in this Facebook Live. As you drive or exercise, you can certainly listen. Please share, please talk about the experience, so that, you know, someone else can benefit. You know, I always like this check and balance, where not only the other surgeons, but I myself, you know, as we move forward in time, that we get this basically feedback, this critical, you know, like someone is watching, you know. And again, this is important for anything in life where, you know, you have, you know, I'm under the radar, you know. And like one of my friends from Philly said, you know, he's a plastic surgeon, and he said, well, Khan, what you're doing is pretty dangerous. And I used the word, and he used the word dangerous, and I said, why do you say that? And he said, you're talking about a topic that's not well described, not well understood, and you're not only talking about it, but you're showing videos, and you're basically putting data, hard evidence. I said, you bet I am. What am I doing? I'm only removing the capsule plus the implant as one system, and I'm doing it in the way that I am. I'm removing it definitively because I believe, and I know from the pathology report, that's where the badness is, and the many patients that have had a significant improvement in their quality of life once the residual capsules were removed. And I'm doing it in the safest manner possible, that I truly believe that should and will be the standard of care in the long run. And he said, well, this is convincing for me, and I feel comfortable, and I see exactly what you said, because the pathology report in itself speaks for itself, and that is the defined way of doing an explant, and no other better way. Well, thank you very much again, everyone. God bless. Hopefully this COVID is history. You know, I'm walking about now without the mask. It's a big relief, and hopefully as we move forward, I look at a time where, you know, we look back at this and say, you know, we made it, and to the many patients that basically, you know, worked with us with their, you know, positive COVID test the last minute, you know, or the many symptoms that they live with, and the many checks and balances that they went through, you know, again, we made it. You know, thank God I have had not a single patient that I operated on who had positive COVID post-op that complicated their recovery, and we all wore the masks, and we followed the rules, and looking back at it and say that hopefully it will only get easier as we move forward, and we'll look at the guidelines such that we offer the surgery in the nicest and the safest manner possible, so that we put the best foot forward. Thank you again, everyone. Take care and have a good night. God bless you all. Bye-bye.